Thank you. It's so good for me always to be here. I started coming to San Francisco General many years ago to do some partnership with KSART at the time. Is KSART still here? Yeah. So, and then after that, Alicia and I worked on the Center for Youth Wellness. Joyce and I have collaborated in some projects, Miriam as well, hi. So it's like coming to see family. So thank you for having me. And the family is expanding now with Will and Barbara. We are getting engaged on a project that hopefully I'll have some time to share with you as well. So we are going to talk about trauma. And there's a number of goals that I have for today. And if I move around, it's still here. So we're going to talk a little bit about the clinical aftermath of trauma because you all know that some of the biological work that we've done with stress and trauma, and then some strategies that have given information that we have developed to prevent. We'll talk about that, and then also to treatment outcome work. At some point, I'm going to have you all stand and do some yoga and mindfulness exercises because we're really into that. And that is the present. And I have some preliminary data that I'll share with you about that as well. Okay, so the battle between nature and nurture is pretty much over. We know that it's really an interaction of these two and how these two alter our stress vulnerability, leading to resilience, PTSD, anxiety, and depression. We still don't understand well resilience, so that is something that we will need to continue exploring. But there's one factor that we know, right? And what is that factor? The presence of an adult in the child's life and how important that is. Now, even that is interesting because there can be something in the kid that makes them seek that kind of relationship as well, right? Now, we need stress, right? We need stress in order to develop. Please come in, and you can sit here in the front if you want. The more stressed we are, the better we perform. If we didn't have any stress, if we didn't care about that exam that we're going to have tomorrow, we'll probably fail. So how do we deal with stress? Well, in many different ways. One of them is all of you and we're going to take a deep breath. We're going to breathe in. And we're going to breathe out. And do that. Consider going up and up. Down.
Is there any way for us to communicate?
I'm going to text Barbara. I don't know if she'll see it.
basically what we do when we do this exercise is that we're moving around.
It probably happened to them last week.
Her.
Like,
And
he
we're
was doing the drum.
Yeah.
It happens a lot, actually.
stress we experience. Like I said, if you don't have any stress, our performance and our health
Yeah.
can be affected. So the more stress you have, the better we perform, but only one optimal point. After that, what we see that our performance, our happiness, our health can be harmed. And it is this second part of the curve that traumatic stress lives. This is what we're going to talk about today. Now, there are many terms out there, and sometimes I worry about this a little bit, right? There's ACEs, traumatic stress, PTSD, toxic stress. I worry sometimes that the message might get a little bit diluted, right? That people may say, well, I learned that about toxic stress, but how does that relate to PTSD? So that's one concern that I have, and I'm going to throw another term to you today, which is allostatic load, which is the accumulation of stressors. The term coined by Bruce McEwen from Rockefeller Center doing animal research work, showing that it's not only like the trauma that you had last week or the trauma that you had a year ago, but it's the accumulation of stressors throughout life. Kind of like the backpack that we all carry. And we all have homeostasis. In the same way that we can manage our temperature, we can carry a heavy bag of stressors. But if we're 5, 6, 7, and the bag gets really, really heavy, we may fall backwards. And that's the allostatic load. That is the accumulation. So the importance of the whole life and the impact of those stressors in physiology carry weight, and it's important. So how do we try to then do this? How do we try to intervene early? Because we know that if we don't intervene early, things are not going to go away, right? In fact, things are going to get worse. And the kids that we work with are going to get engaged with substance abuse, trying to self-medicate and develop other anxiety and depressive events as natural and man-made traumas occur, right? And none of these are isolated, right? We learned from Hurricane Katrina that there was a lot of family separation and loss as well. So that's more stuff on the allostatic load, more stuff on the backpack. Fires, right? An example in... Oh, okay. Okay. Oh, you know what, Ed? I just realized. Okay. Okay, is that better? Other side? Okay, that's good. Thank you. So the Victoria bushfires in Australia is something that also exemplifies this idea of the allostatic load, because these fires happen every year. So while they are still recuperating from the fire from last year, the fires happen again. And of course, we're seeing that in our neighborhood as well. This is a little girl in Haiti after the earthquake there. And we met her and on mental status exam. She looked perfectly fine. She was accompanied by these adults. But as soon as she was able to grab a crayon, she was able to describe how she and her sister were the only survivors that were found in the rubbles of her house. The adults that came with her were actually the neighbors. And so the importance of traumatic play. What we're going to talk today about is interpersonal violence, so sexual abuse, physical abuse, witnessing violence. This has been the bulk of the populations that we see. And Sammy is an example that we're going to be referring to. Sammy is an 11-year-old boy who was brought to our clinic because of increased aggression toward his siblings. Mom reported that this was very uncharacteristic of Sammy's previous demeanor. She also reported decreased academic performance, feeling guilty and confused. She reported to the authorities that Sammy's father had regularly abused her and the children physically and emotionally for a number of years. Sammy had been hit numerous times with metal bars, wooden rods, bamboo sticks. Sammy's mother felt the boy's behavior was directed at her for breaking the family up. Mom and kids were now living in a new apartment. After the father had been arrested and deported, Sammy had nightmares and difficulty sleeping. So this is a typical scenario of a case that we see, and we're going to refer to Sammy from time to time. Let me say right away, though, that I'm going to be talking about a lot of sexy stuff here, brain areas and cortisol and things like that. But today, the best predictor that we have had in our samples for children to develop PTSD is guilt. When you see guilt, if you can tackle that and you can actually work with guilt before you see the symptoms of PTSD, we feel pretty strongly that you can actually prevent PTSD. And not only prevent PTSD, but prevent other anxiety disorders associated with it. And in this scenario, we see guilt not only in the child, but also in the caretaker, which is often the case. Okay, so when a child goes through all of these events, manages all this allostatic load, all of these experiences, we were very interested in figuring out, well, what are the biological implications of this? And the first interest that we had was biological because we felt we needed to differentiate it from ADHD. When I started my fellowship at Stanford 25 years ago, I used to have kids come into the clinic with little notes saying, this kid has ADHD, please place on Ritalin. And I'm like, wow, the diagnosis has been made. There's a treatment plan. Why am I doing a fellowship at all? Why am I training? So some of those kids did have ADHD, as you know, and comorbidity exists between the two. But a lot of them were responding to this allostatic load. A lot of them were responding to the stressors that they were having in their life. Now, something else that is very important in this slide, besides the brain, is the face, is that border there. Because that border shows you the senses, right? The eyes, the nose, the mouth, what you're hearing. And those senses are really the window into, or the door into the central nervous system. And those, we're going to be talking about cues in a second because our treatment protocol anchors in cues. Those cues are going to be, a lot of them are going to be information that we process through our senses and how that gets encoded. So we also were interested in the prefrontal cortex because of executive function, the limbic system, the hippocampus because of memory. As you know, the DSM has had a number of alterations in terms of how we conceptualize PTSD in children. And it has improved, and I think this last one really had a number of things that really has helped it. There's still things that need to be worked on. I'm sure this group is not surprised when I tell them that even with criterion A, we still have a problem because very young children are not that concerned about, or they really don't have a complete understanding of death. So children that are younger than 7, the worst thing that can happen for them might be to be separated from their caretakers, right? So those developmental issues still need to be taken into account when we describe this further. But after that traumatic experience, symptoms of intrusion, like traumatic nightmares, dissociative reactions, we see this in play, right? Someone that went through 9/11. There's actually an older kid that would not play during therapy. He was a talker. He was engaged in talk therapy. But after 9/11, that was the first time he started doing this, and he couldn't talk about it that much. He's a kid that experienced war. So then also avoidance. Now in the DSM-5, avoidance and numbing were separated. I have this phrase that I use that I say PTSD feeds on avoidance. So I think the worst thing that we can do is to avoid PTSD, because there's no way to treat it that way, right? It's like when someone breaks an arm and goes to the emergency room, you're going to have to touch the arm and it's going to hurt, but it's the only way that it can get better. The same with trauma. If you avoid it, if you don't talk about it, if you think it's re-traumatizing, then it's like not touching the arm after the arm has a fracture. The negative alterations in cognitions and mood, I really like that this cluster was included here, because a lot of kids were getting extra diagnosis and diagnosis of major depression, when in fact their mood symptoms were post-traumatic. So that has been helpful. And arousability, of course, and reactivity continues to be there, and now we can emphasize the dissociative symptoms. So when we look at our samples, most of the symptoms that children have are really cognitive in nature, and this was interesting to us because we always conceptualize PTSD as that more of an emotional disorder, but it's really the processing of information, the distressing dreams, the difficulty concentrating, the distressing recollections, the avoidance of thoughts, the inability to recall, that are really the most common in this group. So what is happening to the brain while going through these experiences and while developing, while 100 billion neurons and trillions of synapses are taking place? So we decided to look at cortisol for starters. Cortisol is a hormone that we secrete when we are stressed, a result of the HPA axis. And very early in 2002, we saw that normal cortisol circadian rhythmicity was there, present in both kids with PTSD and the control group. But what we also found was that pre-bedtime, the PTSD group had elevated levels of cortisol. And throughout the years, what we have seen is that this finding keeps repeating itself in all of our samples, to the point that we right now feel that this is really a marker of pediatric PTSD, having elevated levels before bedtime. And it's interesting because it is at nighttime that a lot of the children have a lot of difficulties, either with their sleep or with their nightmares, or with bedwetting, or just being afraid of the dark. And nighttime is a time where, you just have to let it go, right? You have to feel totally relaxed to be able to sleep. This is very difficult for kids to do when they're hypervigilant, but what we see also is that they have these high levels of cortisol. And cortisol has been shown to be neurotoxic to sensitive areas of the brain, like the ones that we talk about, the prefrontal cortex and the hippocampus. So we brought MRI to be able to help us see what structures were being affected. And through software that gets rid of the material that is not brain, that divides tissues, and that superimposes maps. This one in particular is called the Tyler-Rack map. You can actually look at the areas of interest and measure them. But what you can also do with MRI, besides structural imaging, is functional imaging. You can actually give tasks for certain activities, like executive function tasks or memory tasks, and see if those areas are being activated. In this example, what we gave was a memory task, and although volume-wise we couldn't see a lot of differences in the hippocampus, what we actually found was that the hippocampus was being activated significantly more in the healthy kids with no history of trauma, no symptoms, when compared with the kids that had a history of trauma and post-traumatic symptoms. And this is the number of voxels compared to the number of voxels activated in the PTSS group and the control groups. And the control group activating significantly more areas of the hippocampus. So what about the prefrontal cortex? We also saw a relationship there between that high level cortisol pre-bedtime and decreased areas of the frontal cortex, specifically on the left ventral and left inferior prefrontal areas. Usually when you do the go, no go task, this is the task where you press the button every time that you see a letter, but if you see the letter X, you don't press, right? It tests your ability to control that impulse. What you see is that the frontal lobe gets activated in the middle, in the inferior, and in the superior areas. So you expect to see that. And what we see here in the first column, and can you see the red in the back? Yeah, okay. Is that is the middle frontal cortex. And what this is telling us is that the control group is activating that area more than the group that has post-traumatic symptoms. On the second row, what we see is activation of the PTSD group more in the, not the middle, but the medial prefrontal cortex. Many people conceptualize the medial prefrontal cortex as being part of the limbic system as well. It's very involved in emotion, not particularly involved in the go-no-go task. So the question is, why is it activating here? And there's a number of possibilities. One is because of the high comorbidity with anxiety. Another theory could be that in view of less middle frontal activity, you're recruiting areas that are usually very activated, like the medial prefrontal cortex, to get activated to do the task, because the task was done similarly in both groups. Another reason we did MRI is because, as I mentioned earlier, this is a very heterogeneous group. And we could divide kids, for example, that are engaged in self-injury versus the kids that are not engaged in self-injury. And what we see at the bottom is the insula being activated significantly more in the kids that are engaged in self-injurious behaviors. The insula is a cortical temporal area, and it's not easy to get at. It's very insulated. It kind of goes into the temporal lobe. But we're going to be hearing more about it because the relationship between insula activation and PTSD symptoms is pretty high. What we have found here was a correlation really of 0.8 between all the symptoms as the kids were developing symptoms and their activation of the insula. So why do this work, right? Why do we need to know what happens in the brain of kids that are developing symptoms of PTSD? One of the things that we know from neuroscience work is that your brain function and your neuroscientific findings and chemistry change before behavior changes. So if we want to add empirical data to the treatments that we use, this is a very good way to actually see, well, are these treatments creating a change in these areas even before we see the behavioral changes. In the amygdala, for example, we talk about hypervigilance, but what is hypervigilance really? Well, we think that we know what it is in terms of having increased amygdala activation. These are kids, the red line is the kids with PTSD presented with images that are that people that are experiencing fear or people that are experiencing anger. And what you can see on the early block is that amygdala immediately gets activated significantly more than the control groups. And usually you have a good prefrontal cortex that can help serve as a brake to that. But what we see here when we look at the prefrontal cortex is that it's actually activating less than in the controls. So there's something not working right in this frontal limbic pathway where the gas and the pedal are not totally aligned. So now when we talk about hypervigilance, we feel that this is what's happening here. So the importance is to identify kids that can be at risk of developing PTSD. Maybe we can find these things even before they have the symptoms. Things like high levels of cortisol, early amygdala reactivity, and diminished prefrontal activity. Now, that all sounds like bad news, and in fact it was for us for all the years that we got started. But then we started thinking, well, what this is telling us is that environment can have a big impact on biology, right? And yeah, we've been studying one side of the coin, that in fact, when something bad happens, that can have a negative consequence on how your brain develops and functions. But what's on the other side of the coin, right? What happens when we make that environment better? Or what happens when environment is good? What happens to those things? So that's what we want to see when we do treatment outcome research. And these areas that we're talking about, the cortical areas and the limbic areas, which are the most complex areas, are also the most plastic areas in the brain. So they actually can be very available for our interventions to cause a change. And behaviorally, we know that many of the things that we do improve the socio-emotional development of children. But could we make them even more focused and more targeted by knowing which are the components that are actually creating most of the change? Because when we have an health access problem, right, and we have to take care of so many individuals, maybe the long-term therapies that we have now can be made more focused and more targeted. So that's one of the goals. And we need to develop treatments, right? So one of the things that we know is that without treatment, PTSD can become a chronic condition, and that not only that, it can worsen. I mean, if we have some, depression is a very severe illness, right? It can lead to suicide and all of that. But if you look at the lifespan of a depressive episode, it's 6 to 7 months with kids and with adults. If you manage to survive it, it will be over, right? It may come again, and it may come faster because of the kindling process. But it has this natural life history, natural lifespan. PTSD doesn't have that. PTSD just continues to grow. You don't see it all the time because you need the input of cues and triggers, and that's when you see it, and some people have more cues than others, but it's there all the time. And if not attended to, it's not going to go away. It's just going to get worsened by comorbidity, by substance abuse, by self-injurious behaviors. So we need to attend to it, and we need to develop new treatments. And treatments have been developed here, treatments have been developed in our group, treatments have existed, but I really exhort everyone to continue to develop even more, because like I said, and I continue saying, this is a very heterogeneous group, and we don't have algorithms of care, right? If a 14-year-old girl shows up after an episode of sexual abuse, and a 5-year-old boy shows up after a motor vehicle accident, they'll probably get treated not that differently. And we need to make those differentiations, and we need to see who responds to what components are important for whom, and so forth. So I'm just going to talk about one approach that worked for me, because what I was seeing was that there were a lot of kids that were ready to do the work, and their parents were not. And the treatments were telling me, well, caretakers need to be involved. And I'm like, yeah, but it's not like, I can force them. And sometimes it's not avoidance from the parents either. Some parents, if they, lose one day from work, they lose their job. So there are very practical reasons. And so I was seeing kids that were ready to do the work, but were not doing it. And so that's one thing. So then we decided to, and then with this whole idea of the allostatic load, we also felt that it was important. Sometimes when we were asking kids, tell me about your trauma, they would look at us like we had two heads. It's like, what are you talking about? It's like my whole life, really. It's this backpack, right? So we developed this to pay attention to the fact that what can we do if parents are minimally involved or not involved? What can we do when trauma as an entity is not that clearly demarcated, but we know they're having post-traumatic symptoms? What can we do when physiological presentations come that are not part of your usual cognitive behavioral therapy triangle? of thought, behavior, and feeling, right? But we're talking about a physiological feeling. So we're changing that triangle to a square a little bit. And this is what we came up with. We came up with an intervention that is short-term, 15 to 18 sessions, which is a hybrid of things that they're not going to be surprising to anyone here. You've heard about them, exposure, narrative. So the content, the what we're all familiar with, is more about the how. It's more about the process of how we do this. Because one of the things that we try to do while we're doing CCT is to improve the self-efficacy and the empowerment of the child. When you think about, we do therapy to give kids coping tools that they can take with themselves for life. The most important coping tool that they're going to have is themselves, is their body, right? We all were able to work with our body just a few minutes ago by taking some deep breaths. Did that work for you? Yes. Did that work for you? No. You make the decision if it's going to go to your toolbox, right? So the kids in CCT have a toolbox where they add tools that are helpful for them. And if they're not helpful. And if they create it themselves, those are excellent. So let me tell you how I learned this. So I was treating this girl, right? And I was teaching her one day the breathing exercises, mindfulness, muscle relaxation. The assignment was for her to practice during the week and to come back, and then we will decide what goes into the toolbox. And she was very anxious, and she had a lot of ruminating negative thoughts. When she came the week after, she felt a lot better. She really was less anxious. And I'm like, wow, the exercises really help, right? And she's like, no, actually, I don't remember the exercises. But I remember that we did something about it. So what I did was that every time I felt bad, I had a glass of milk. And I told myself, after I drink a glass of milk, I'm going to feel better. At that moment, I knew I could go two ways, right? I could go and say, oh, no, you have to practice. You have to practice these exercises. Or, and this is what I did, you could say, fantastic, drinking a glass of milk. What a great coping tool. Do you want to put it on your toolbox? Which she did. And then from that moment on, what we were seeing it was that when kids develop their own coping tools, those are usually even stronger and have better outcome than anything else we can teach them. And that has to do with empowerment, right? That has to do with self-efficacy. That has to do with being a partner in treatment. Remember that a lot of these kids, things were done to them, right? That's why they are seeing us, because kids, things were done to them. We don't want therapy to be another experience where something else is being done to them, right? Let's do this together. Let's partner. You start thinking about what you think the cues are for you and start creating this list of potential cues. So with CCT, we aim to reduce negative cognitions, express emotions regarding the trauma, identify and change trauma-related behavioral responses. So we talk about the behavioral responses as a square. And what we do literally is we teach classical conditioning to kids. And we see, you learn this response that probably was adaptive at one point, but it has become now maladaptive. So the 7-year-old boy who last year experienced a lot of fights between his parents and he used to run to his room and close the door, learned that that was something that would protect him from whatever was happening. And not only he learned it cognitively, his body learned it, like automatically. So a year later, when he's in the classroom and the noise gets really hard and he starts running out of the classroom, his body's coming up with the response he has. He knows what to do at that time. Only that now is maladaptive because he gets sent to the principal and no one knows why he's doing this, right? There's no context. So he gets labels, and he gets labels of being bad, of being crazy, being a problem. And he doesn't know why he's doing it either. So he absorbs those words at a very critical time in his development when he's forming his identity. And he says, well, I guess I have to behave like I'm a problem or I'm bad because that's part of my identity, that's part of who I am. So teaching kids about trauma, teaching kids about PTSD, teaching kids classical conditioning, teaching kids how a response is like a square, where you think about something, you feel a certain way, you do something, you feel physically a certain way, is important. They understand it, they get it, and they feel control because now they can create new squares. They can create new responses. This is not about you need to stop running out of the classroom, because when you do that, you're basically asking them, oh, I see that you have one tool in your toolbox. Can I have it? Right? So you don't want that. You want them to add more tools in their toolbox. And when that happens, guess what happens to that original behavior? It starts to extinguish. So we wanted to see if this would work, right? So we did a randomized controlled trial. We had some kids go through the treatment. And then the kids that were on the wait list eventually got the treatment as well. And we saw decrease of PTSD symptoms that were significantly more in the kids that did CCT when we asked the parents and when we asked the kids. Usually when you start anything, anxiety decreases, and we can see that here, but then we can see that with CCT, the gains were maintained and continued in terms of decreasing the symptoms. And this is how, through the whole course of CCT, the symptoms decrease. So the biggest slope here happens around session 2 to 3. And what's happening there is none of this fancy narrative and exposure and things that we all do. That happens later and it continues to help. But what happens very early on is just telling them what's going on. It's education. You are not weird, right? 99.9% of us, if we went through something similar with a bag as heavy as the one that you have, would probably come up with behaviors that were that way. That's what we're doing. We're teaching classical conditioning, and that has a big impact at the beginning. It could also be an order effect. We haven't checked for that yet. Okay, so classical conditioning, right? Unconditional stimulus, the trauma. Unconditional response, the adaptive response to the trauma. The conditioned stimulus is the cue. And this is what we concentrate on with cue-centered therapy. It's kind of a here and now type of approach. And the conditioned response is the maladaptive response in a non-threatening situation. So it's important to pay attention to cues, emphasize self-efficacy, empowerment, use adults as coaches whenever available, and teach these 4 components. And so we do education, we do mindfulness, relaxation, and cognitive tools in the way that we practice them this morning. We do, instead of a trauma narrative, we do what we call the chronic traumatic stress history, where we actually have a lifeline. And if the child is 9 years old, for example, we go through the 9 years. It's not that long, it's only 9. And we have above the line positive events, right? We look at it in context. Below the line, negative events, and then neutral events. Usually we make a circle on the negative events and we say this is what we mean by the backpack or the allostatic load. So we can always refer back to that, right? And the kid doesn't have to feel like, oh, was it that my dog died, last month, or was it the fire that happened, a year ago? During the mid-therapy update, we try to engage the caretaker, and the kid, supported by the therapist, gives an update. It's almost like modeling to the parent about the work that has been done. Something that also happens when the parent is not there is that the kid is more active, more engaged, which is interesting. It's like a good side effect. Then we start working with the cues, and we do exposure in a gradual fashion. We check on that traumatic stress history again. But through all of this, we're working with the manual, and the manual tells you what materials you need for each session, the outline, the goals for that session, and the principles. So something that Judy Cohen always refers to is the cow, right? The crisis of the week, and how that interrupts the progress of what needs to happen in that session. So having a very structured way of saying, doesn't matter what happens, this has to happen during this session, is helpful, because then the therapists can actually work in a way that maybe they can combine things and get these things done as well. One of the flexibilities of CCT is that, well, there's two aspects. When you're working with the square, you don't have to change all of the squares, but you can choose which corner you want to start. So depending on the temperament of the child, if he's very cognitive or very physical, or he doesn't want to do it, and he will just say, okay, I'll just do another behavior. You can start in different corners with different kids. The other thing is that who you are as a therapist should not change because you have a protocol in front of you, right? The kid is going to start staring at you like, what happened to you? Where did my therapist go? So this encourages you to continue to use your strengths, but with these objectives in mind, basically. So if you're doing a lot of art, or if you're even doing music or whatever you're doing, keep doing it, but try to reach these goals during that session. This is the square. This is the toolbox where they get to add their coping tools, and then we use this feeling thermometer developed by Wagner to communicate during exposure, and also for them themselves to use it as a potential tool that they can add to their toolbox. So let's go back to Sammy for a second and recall that this is a boy, right, that experienced physical abuse. But in this savvy audience, I'm sure you were thinking that this is not only a kid that experienced physical abuse, right? This is a kid also that experienced separation from his father when the father was deported. And Sammy said that in very good words. He said, you know what? I feel very good that nothing bad is happening to me now, but not every day was bad, and I miss those days. Sometimes we would go to the park, sometimes we would have ice cream, and that's not happening anymore, right? So it's a lot more complex. The requirement to have to move means that there's a requirement for a new school, so adaptation to that. So trauma is complex. Trauma has many layers. Sammy certainly experienced loss. He experienced the severity of physical abuse. I don't want to minimize that. And then how would he get treated with CCT? Well, the first thing was education into the symptoms. And that enabled mom to manage Sammy's nighttime episodes. For the mom, Sammy was a cue. So what the mom was doing is what we do with cues, we avoid them. So she was avoiding Sammy at a time when Sammy needed her the most, right? Sammy found relaxation exercises were good for him because they gave him control and a feeling of calmness. So he started doing relaxation exercises. And then with support guidance, and very important is structured means to avoid suggestion, Sammy told his story. He now felt safe. His sense of security increased further as mom learned not to avoid him, but he also missed his father. During the aggressive episodes, he felt confused, as in a daze, and his heart rate would accelerate. After taking out his feelings on his siblings, he would feel guilty and he would feel ashamed. And remember what I told you about guilt. So Sammy and his mother were introduced to the concept of traumatic cues and reminders and classical conditioning and the whole thing. And then Sammy himself started thinking after this that the slamming of the car door when mom was coming home reminded him of his father coming home. His brain would associate that sound with the fear that there was going to be violence. And mom is like, oh, I can get rid of the car. And I'm like, no, get rid of the car. Cues are mostly neutral, right? In fact, they're going to help us through the process. So when exposed to the cue, an aggressive response would result. Sammy would be hypervigilant. He would identify with the aggressor, right? And then we started, so that was his response. That was his square. So we started developing new squares. And how could he have new squares when this sound happened? Although impossible to identify all cues, and that's impossible because most cues are unconscious, right? So all we need is like 3 or 5 that we can work with. And then once we learn the lesson that, oh, it looks like we respond to cues, then you can think when something happens, maybe I just responded to a cue, right? You don't need to know what the cue is. But you need that, like a few to do some work and make a connection. Kids compartmentalize a lot. They know that the history happened. They know that they may have feelings of fear, sadness, and anger, and they also know that they are doing behaviors, right, that are getting them in trouble, but they don't necessarily connect all of those. CBT doesn't do that. That's insight-oriented work. So we try to include this here as well through some instruments that help the kid make those connections in a very simple way. I mean, he's asking, well, when I'm sad, what do I do? Or I am angry because, or, you know, and then we have like a form B for the kids that say that they're not angry or sad. Well, if I were angry or if I were sad, I would, and they answer exactly what they're doing in it. So anyway, you need to take the whole training for that one. So he developed a lot of self-efficacy. He learned to process discordant emotions. By termination, he was doing better at school, not arguing with his mom, not hitting his siblings, and feeling better and not clinical PTSD symptoms. So of course, this is a pretty straightforward case, right? That's why I'm presenting it. It can be more complex than this. You sometimes have to do it twice, but that's how it goes. So now what we are in the process, in collaboration with Judy Cohen, is to compare cue-centered therapy with trauma-focused cognitive behavioral therapy and with treatment as usual at 2 sites. One, the Stanford Youth Solutions, no affiliation. This is an agency in Sacramento that was also an orphanage that was started by Leland Stanford, so that's the connection, but eventually became a trauma center, and they see a lot of kids in the county that have trauma, and the collaboration here with you all, with you guys. And what we want to do this time is, this is not to show that one treatment is better than the other, but is to start identifying which are the kids that are responding to which components. And so we expect not only positive results from TFCBT, because obviously the literature is very rich on that. We expect positive results there. We expect positive results with CCT. And we expect positive results with treatment as usual, which is something that they do in Sacramento, which is whatever it takes type of approach. But we really want to start getting to, you know, which one is better for which group, or which kids use which components better. So that's the goal of this. And the way that we're going to be assessing it, and we are assessing it already, is by using FNIRS. So this time no MRI, but FNIRS, which is actually like a swimming cap that someone puts on their head and gives you information on the cortical activity of the brain. So you can get to processes of memory that happen in the prefrontal cortex and also executive function. It's actually better than the MRI in terms of timing. It's more real to what's actually happening. The limitation is that it doesn't give you the same level of validity for subcortical data. So when you look at the hippocampus and the amygdala, that is not as well, but that's okay, because we want to concentrate on this executive function piece. Then we're looking at anxiety, at PTSD symptoms, at executive function through the brief, at trauma symptoms, and we're assessing kids at baseline, at mid-therapy, at end of therapy, and 3-month follow-up. And so that's ongoing, and it would be great to come next year or maybe 2 years from now and share some of those results with you as well. And then the other thing that I told you about is this yoga and mindfulness that 3,600 kids in East Palo Alto have done for the past 3 years. And obviously I was not going to research all of those kids. So we concentrated on the 3rd graders and on the 5th graders and during the first year, and then followed them. But I wish I would have followed the kindergartner because they have done great. For the kindergartners, this is not an intervention. This is like brushing their teeth. This is part of what they are. They teach it to other kids. They go and do it on their own during recess time. I mean, they have been amazing. So the younger they are, the better. The 3rd graders are doing better than the 5th graders. But the kids are really having, the study is complete. The 3 years have passed already. So now we are just starting to look at the data. It has been a collaboration with not only the East Palo Alto School District, which was the experimental group, but also a district in San Jose, the Alum Rock, which sociodemographically is similar and went through all the evaluations without receiving the intervention. They're going to be receiving it now. They're going to be getting training on how to do the yoga and the mindfulness. So one of the first things that we have looked at, and I'm glad to be able to share this with you, is that the curriculum is called Pure Power. It's by this group called Pure Edge. And they have this Pure Power curriculum, which is yoga and mindfulness together. And you can see how those kids in the control group with low initial symptoms, their symptoms throughout the 3 years have increased, which is what we see with kids when they go through puberty. Boys and girls, they all increase in terms of symptoms. Those that have high symptoms have maintained these internalizing symptoms, anxiety and depression from the BASC. With Pure Power, those that had higher symptoms, we have seen the symptoms decrease. And those that have low initial symptoms, we see them be, stable. And that concerned me at some point. Why are they stable? They should come down too. But then I got reminded by Carl Weems, my collaborator, methodologist person, that this is prevention. This is not a treatment intervention. So this is as good as it gets when you actually are just trying to prevent something that most of the kids don't even have it, right? But you just don't want them to develop it. So we're feeling very positive about this. It's all preliminary data. We also did polysomnography. And what we're seeing there is an improvement in terms of total sleep and REM sleep. This is a population that was spending, even though they were not, it's a community sample, they were spending very little time in REM. And REM throughout development just decreases. What we're seeing is that REM and deep sleep is increasing in kids that are doing the yoga and the mindfulness. Also, we're seeing some good findings in terms of executive function, but very little numbers there, but we'll tell you more about that later. Just a final word to remind everyone that everything I've talked about today is not only the microsystem, it's the micro system, because I'm talking about the brain, right? But let's remember the ecological approach. How kids do depend not only on themselves and on their backpack, but on the family, classroom, peers, religious setting, ecosystem, school, community, and society in general, right? We have a definition for trauma-informed system. Here it is. This is something that we work with a group in San Diego for some time. And it's important when we're working with places, and this is a very trauma-informed place, so I'm not going to spend a lot of time here, but it is important that we have that definition as well. So thank you. It's 12:59, so we have 1 minute for questions. Okay, questions? Miriam. I know, not in terms of research, but clinically, like you, I see it over and over again. And what's interesting sometimes is seeing all the symptoms of PTSD in a child that has no trauma history. And then you go and you meet the parent and you talk to the parent and you find the trauma there. And sometimes you don't only find the trauma, but you find the guilt as well. And the behavior has been modeled. And the kid has learned, not to trust, to be hypervigilant, all of these things. But no, it would be very, very important to assess that as well from caretakers.
Thank you so much for your PowerPoint. Would you have a question?
Yeah. Okay, well, thank you. Thank you so much. And it's been a pleasure, and I'll see you next time.